Hi, this is Dr. Tara Gregory with the Colorado Blood Cancer Institute. I've spoken to you guys before, and thank you so much for having me back. Today, what we're going to talk about is a new area of what I do. I know you guys know that I do stem cell transplant, but the type of therapy that I do has broadened its horizons, and now we're referring to it as cellular therapy. So our national meeting, instead of being ASBMT, is now ASTCT, the American Society of Transplant and Cellular Therapies. And today we're going to talk about a new type of cellular therapy that's coming out there where nurses are incredibly important in the management of these patients, and it's called Chimeric Antigen Receptor T-Cell Therapy, and for short we call it CAR T-Cell Therapy. And my nurse Tessa is going to help me with this presentation today as well. So first of all, what we're going to do is we're going to talk about the differences between a transplant and cellular therapy. We'll talk a little bit about how we use cellular therapy and CAR T therapy, and then what are the major complications of CAR T therapy. And that's really where it's so important to have nursing on our team who's well-versed in this treatment. So first of all, just taking you back to how blood works. Amazing picture of a bone, because this is what they look like. And as you recall, inside the bones is the special blood called bone marrow, and that's what makes the blood that floats around in the body. And inside there are these special blood maker stem cells, and they can't make hair, they can't make babies. All they do is make blood. And so remember, we have special cells in our blood. We have our myeloid progenitors, and those can make platelets that are the sticky cells that keep us from bleeding, red blood cells that carry the oxygen around our body, and then white blood cells that help fight infection. And then the white blood cells that come out of the myeloid line are typically like our neutrophils. So neutrophils, basophils, eosinophils, they're all our phils. And what they do is they help us fight off infection that's come into the body like right off the bat. So they're like your ground army against infection. On the other side of things, we have our lymphoid progenitors. And so those are the cells that help us make antibodies, help us fight off infections long-term, but also have some special, immediate effects. And then also cells called natural killer cells. Those are like one of the best. They like crawl across enemy lines and help eat up cancer cells. And actually there's videos of them like crawling and just landing on a cancer cell and eating it. So we have the T lymphocytes, the B lymphocytes. B lymphocytes can hang out and be what they are, or they can turn into my favorite cell, which is the plasma cell that makes antibodies that fight off infection. So you can see that little fried egg in the bottom over there. And then our natural killer cells that we talked about. So those are our basics. So when people get a blood cancer, they're getting a blood cancer in one of these different cell lines. So the cell was trying to be something and it didn't make it, or it reverted back and it turned into cancer. So we have our lymphocytic disorders. So we have acute lymphocytic leukemia. We have lymphomas where we make big lumps of tissue. And there's Hodgkin's lymphoma and T-cell lymphoma and B-cell lymphomas. And they're ones that grow really fast and can hurt people very quickly. Those are called aggressives. And then we have ones that grow more slowly or slower. And those ones are what we call indolents. On the plasma cell side of things, so that's what I mainly treat, is multiple myeloma, where you're making an abnormal protein that causes the problem, and then amyloidosis, where the protein doesn't work or form quite right and goes and gets stuck in an organ and freezes the organ up so the organ doesn't work because it's kind of like it's filled with super glue. And then we have our myeloid diseases. So that can be like acute myeloid leukemia, pre-leukemia conditions, so where the bone marrow is just not working right and eventually it will develop cancer. So that's myelodysplastic syndrome. There's chronic myelogenous leukemia. That's where we use drugs like Gleevec that you guys have heard about, or imatinib. And then there's a lot of different drugs that are out there as well. And then some of these other types of what we call myeloproliferative neoplasms. What that basically means is that the cell decided it wanted to make too many red blood cells. So that's polycythemia vera, or make too many platelets, and that's essential thrombocytosis. And in those diseases is that if you let the bone marrow just kind of keep churning and burning, it's eventually going to fry out and can cause myelofibrosis, where the bone marrow completely scars up and doesn't make cells anymore. And then that can lead to acute leukemia, or just these diseases themselves can lead to acute leukemia. So that's our refresher on some of the diseases that we're treating. Today, we're going to mainly focus on the lymphocytic disorders. So stem cell transplants are what have really helped us in blood cancer help patients survive longer. And in auto transplants, what happens is we get the patient's blood maker stem cells out of them first. Then we give them massive doses of chemotherapy that are really good at killing their cancer, but it kills their bone marrow too. And we can't leave a patient like that. So what we do is we collect the stem cells, put them in the freezer, give the patients big chemo to wipe out their bone marrow or to wipe out their cancer. And then next we put their blood maker stem cells that are stored in the freezer, thaw them out, drip them into their veins. And within 14 days, it regrows that bone marrow that we just fried with all that chemo. But if you look at this here, this is just kind of like all diseases from the Centers for International Blood Marrow Transplant. If people die after an auto stem cell transplant, about 71% of those patients are dying because their disease came back. And so that's called their disease-related mortality or relapse-related mortality. And if we do stem cell transplants where we get the cells from a donor, and the reason that we would do that is because chemotherapy is never going to be enough to help this cancer stay away. This patient needs a new immune system that's going to see its cancer as foreign, or see the cancer as foreign and fight it off for them. So it's an immune attack. Those are allo transplants or allogeneic stem cell transplants. You can see again, the vast majority of patients are dying because the disease came back. And it's disease-related mortality. So what are we going to be able to do next to help patients maybe avoid these therapies that are crude and have a lot of different toxicities associated with them, or for patients where these treatments didn't work and we need to offer them something else? And so that's where cellular therapy comes in. And here's where we're getting very excited about, you can see the arrow pointing to the T-cell. And then eventually, and not ready for prime time yet, but those natural killer cells are going to come out. You're going to see those more often now in the next, like I would say, 5 years. So what CAR T-cell therapy is, we put the patient on my machine, and instead of setting the machine for stem cells, we set the machine for T-cells. And the beautiful thing about T-cells is that they live in your bloodstream and they're there already, and you don't have to get them to move from the bone marrow out into the blood like we do with stem cells. And we hook the patient up to the machine, kind of looks like dialysis. It's called apheresis. And we run the blood through the machine. It plucks out the stem cells, puts it in a bag. We ship that bag out to a company, and the company then infects the stem cells. Well, first it grows them, which is step 2. And step 3 is that they get infected with kind of like almost a virus-like particle that then makes that T cell see the cancer as foreign. And then we grow that product up and they ship it back to us. And what happens next after they ship it back to us is that the patient starts some chemotherapy and the product, so the cells are frozen. And so the patient starts what we call conditioning therapy, which is that orange arrow, days -7 to -3 kind of in there. And they get 3 days of chemo. And what that chemo is doing is it's knocking down the person's immune system, because we don't want to put these funny looking T cells back in and have, the natural immune system go and fight it off and eat it. So we call that lymphodepleting chemotherapy, or LDC chemo. And it's usually a combination of fludarabine for 3 days and Cytoxin for 3 days, same 3 days they do that in clinic. They get 2 days off traditionally. So we usually do chemo Wednesday, Thursday, Friday, weekend off, and then put the CAR T cells back in on a on a Monday. And then we wait for them to take over and grow. Right now, these are traditionally done, inpatient when we put the cells in. So the patient does outpatient chemo. They come into the hospital on Monday, get their cells, and then they discharge within a week. And we'll talk more about why they're in the hospital for a week in a few minutes here. But we're starting to work on doing these as outpatient procedures as well. So what are we doing to these cells to make them see cancer as foreign? So we've done a bunch of things, and we've been through the last few years a couple different ways of doing this. And so what you can see here on the right, where it says endogenous TCR, that stands for T-cell receptor. It's basically what your immune system does. Is I always say it's like a toddler. It's running around and it's just touching things and it's putting stuff in its mouth. And it's like, do I know what this is? Do I not know what this is? And if it hits something that doesn't match, it's like, oh, that's not me. I should eat it. And so what we want to do is we want to get the immune system to start touching the cancer cell and say, that's not me, I should eat it. And what we do is we pick a receptor that lives on the cancer cell. So this is our receptor. And we want that T cell to come in and lock on and be like, yep, that's not me, I should eat that. And so because we're putting that DNA information in there, And because it's two types of DNA, the patient's and the virus, that helped infect it, that's called chimeric, two types of DNA. Antigen, because it's seeing this thing that's hanging on the cancer cell as foreign, and it's a receptor T-cell. So we've been through different generations of how to make the cells see these cancers as foreign. And what you can see is that on the top line, this is all staying pretty similar, but on the bottom, we started adding things. And when we add things, it makes that T cell more specific. It makes it react better. And so now we're on to what we call third generation CARs. And then we're going to fourth generation CARs or trucks that have a lot of different signaling and DNA information that's taking place as well. So it has been gangbusters, and it's killing me because I got to learn how to say all these new words. So bear with me because I'm kind of getting there. But we have some on the market CAR T-cell therapies currently approved. My research is in multiple myeloma CAR T-cells. None of those are FDA approved at this time. Maybe this close to the summer, we'll have 2 coming really quickly. But right now we have a bunch for the lymphoid disorders. So the first one is axicaptogene Silolucel, so we call it Axi-cell, and the trade name is Yescarta. And it is used to treat patients who have aggressive lymphomas, so large cell lymphoma, primary mediastinal B cell, high-grade B cell lymphomas, transformed follicular lymphoma after 2 or more lines of therapy. So that's one, Yescarta. Then we have Tessa-cel, also known as Chimera, treats that same population, but also can treat patients who are up to 25 years old with relapsed acute lymphoblastic leukemia. Then there's Liso-cel, or Breyanzi, I think is how you say it. And that one was approved for diffuse large B-cell lymphoma as well. And pretty soon it's going to be coming with some other indications, probably maybe by the time this talk is visible for you guys. We'll have some new indications for that one. And then the last one is Tecartus or Bruxa-cel, and that can treat mantle cell lymphoma patients who haven't responded to previous therapy or who have had 2 or more kinds of, or have relapsed after a treatment. And these can only be administered at sites of excellence. So the sites of excellence. So usually you're going to see these right now administered in a transplant program. Eventually so many patients are going to be getting these cellular therapies. It's, I'm sure that transplant programs just aren't going to be enough of us to help do this. So eventually I think we'll see oncologists in the community offering these therapies as well, but it'll take a bit. So these therapies, what they stick to is called CD19. So I'm sure you've all heard of rituximab or Rituxan, and that's an antibody treatment that sticks to CD20, but these are sticking to CD19. So it's pretty widely expressed on lymphoid cells. So that one's been pretty successful. So, well, how well do these things work? So this is the therapy for the aggressive lymphomas. So remember, we can have Axi-cell, Tessa-cell, and Liso-cell, which can treat these groups. So we have 3 different CAR Ts. And usually we'd say that a transplant, like so if we did an auto transplant, we'd be happy if like 60 to 40% of those patients had their lymphoma stay away long-term. And if you look here, we're seeing an overall response rate of 82% and making lymphoma go away in about 50, anywhere from like 40 to 50% of patients. But when we look at these responses, these responses are lasting, quite some time, around 15 to 19 months. And these are therapies are traditionally done in patients where chemo doesn't work for them or they already had a transplant. So those patients, if a transplant didn't work and they needed something else, the options weren't too great. And eventually they were going to relapse and pass away. And with these therapies, we're seeing what we call durable remissions, where the patient's disease is staying under control for long periods of time. Now, these are newer therapies, so we don't have a ton of long-term data on them. We're following them on average, kind of like 18 months, 19 months to see how things go. But that's actually looking pretty fantastic compared to things that we've had available before. This is the Tessa-cell product for acute lymphoblastic leukemia. So again, terrible. If your patient, fails to respond after chemotherapy or relapses after chemotherapy for ALL in this age group, their chance of making it long-term is very low, less than 50%. So, and their chance of responding to treatment is less than 50%. So the fact that we're getting an overall response rate and putting people in remission to the tune of over 80% is great. And then last but not least, mantle cell lymphoma can be a very difficult disease to treat. And so your average patient gets chemo and goes to an auto transplant. So if they relapse after that, we really haven't had a lot of therapies that we can offer that will put them back into remission and potentially keep them there. And so now we're seeing an overall response rate of 87% with this product, and long-term survivals of 83%, at a year. So really making some gains. So what else are we doing at CBCI? Well, at CBCI, we have other anti-CD19 therapies. We're starting to use CAR Ts as outpatients. Maybe you can't even get your T cells collected because your T cells are too low based on all the therapy you've gone through. So maybe we should get these T cells from somebody else. And those are called allogeneic CAR T cells. We have those studies. I have 4 different myeloma therapies for CAR T for BCMA, which is our target. Instead of CD19, we use B-cell maturation antigen. And then another one, which is a new target for myeloma CAR T, is called GPRD5C. And then some different T-cell therapies for acute myeloid leukemia. So, all right, that sounds great, but what's bad? Well, these things are expensive. So if you have commercial therapy, what we do is we have to have an individual contract for you with your insurance company to move ahead. That has to get approved through a lot of different people. But if you have Medicare, Medicare has said, we will pay you $239,000 and $928, to reimburse you. Well, what's the cost of just making the product? It's about $300,000 to $500,000. So that doesn't even pay for the product cost. Then you have to go in the hospital. And if you get sick and you're in the hospital for, over like a week to a month, that's an expensive bill, and Medicare's not paying that. So that's really difficult. A lot of the conditions that you have as a result of CAR T-cell therapy don't even have CMS codes, so we can't bill against those, but those are coming. So, cost has really been a big issue. So there's been a lot of advocacy on the part of our national organizations to help increase reimbursements, educate doctors on how to bill costs appropriately so that we can start to get these therapies paid for. How about time frame? Can take anywhere from like 3 to 4 to even 6 weeks on some products for these T cells to be made and grown and shipped back. So if your patient has a cancer that's really out of control and you got to figure out a way to collect their T cells and then keep their disease under control while you're waiting for the T cells to show up, that's a challenge as well. So maybe we should be using off-the-shelf products that are already made. So when a patient needs it, we just grab them and they're from some kind of unrelated donor. Do we need to change our production, issues, do them locally? How do we bridge therapy, which is where we keep disease under control while we're waiting? Now, this is where Tessa is going to help us out on these 2 key things. So if I lost you guys, I need you to come back to me now. The big complications medically that we're seeing from CAR T-cell therapy is that the immune system gets in there, those T cells, and they start to see what's foreign and they start growing and expanding and getting after it. And when your immune system gets excited, it starts to release a bunch of things called cytokines. And cytokines are what cause you to have high fevers and low blood pressure and swell. And so you can imagine that if this immune system gets really excited because it sees cancer cells, it's gonna, really make you sick. And we call that cytokine release syndrome, or CRS. And so what happens is that when we put the cells in, we wait and we know with certain products that we're going to start to see a reaction within a couple days. And we have to monitor this reaction appropriately because we want to let the cells be active to fight off cancer, but we don't want to let them be so active that our patient dies or, has multipressors that they have to be on and intubated. So, it's pretty common that we see some degree of cytokine release syndrome, but it's uncommon to see the type that can end people's lives or make them really ill in ICU. But right now, that's why we're keeping patients in the hospital for about a week so that we can monitor them and then get them started on treatment quickly. When we treat patients, we think about, are you at risk for CRS? So the more cancer they have in their body, the more that those cells can see, the worse off they'll be. We're trying to make sure that patients, are strong enough to go through this. And then the way that we treat this is with specific drugs that block those inflammatory cytokines to shut off the signal, that you're irritated. And then if we have to, we can use steroids. And then some of these products come with suicide switches where you can just turn off the T cells by giving a specific drug. Granted, we don't want to do that if we don't have to, but if we have to, we will. The next thing is that this immune system can cause big reactions in the brain, and that can cause, brain swelling. And so we can see things like people just aren't quite themselves, they can't write appropriately, they're confused, but we can go all and maybe shaky. But then you can also see patients go all the way to having seizures and becoming obtunded and intubated to protect their airways. So it's pretty rare to see what we call neurotoxicity, and it's ICANS is also the term that we use here, but it's a big deal when it happens. A lot of the drugs that we use to block the inflammatory proteins don't work in the brain. Some do, some don't. But then if we can use steroids appropriately and shut off that signal before somebody has a seizure, that's what's important. I think we talked a little bit about this. So what I'm going to have Tessa help me with is that she and the different nurses in our clinic and then on the nursing floor go through specific assessments, and they're called the ICE and ICANS assessments. And these are our CRS and neurotoxicity assessments that then we add these scores together, and we see these patients every single day from the day they get their cells through day 30 to monitor and see what's going on. And then we use this to decide, do we need to use steroids? Do we need to give them some TOSI? What should we do with them? So I'm going to let Tessa take it from here.
Hi, everyone. My name's Tessa. Okay, so this is our assessment sheet that we use in the clinic. And like Dr. Gregory said, the patient is seen daily until day plus 30, and they are given this assessment each day that they come into the clinic to monitor for any of the signs and symptoms associated with CRS and any neurotoxicity. So on the first page, you can see the first thing we do is the ICE assessment. It asks basic orientation questions, naming objects, following basic commands, attention, so counting backwards from 100 by 10, and then a short writing sample that's the same sentence each time. At this point, I also like to ask the patient's caregiver if they've noticed any changes that the patient wouldn't necessarily notice themselves. These patients are required to have a 24-hour caregiver for the first 30 days post-CAR T, and so they're closely monitored by someone within their close network of caregivers. And sometimes people are able to catch things that the patient wouldn't notice themselves. So usually I'll ask them if they've noticed the patient forgetting words or misplacing items more than usual. And they can be a really helpful tool as well. The second thing on this first page is the ICANS. And so it uses different neurologic scoring to show if the patient's having any neurotoxicity symptoms. So depressed level of consciousness, any seizure activity, motor findings, and any evidence of elevated ICP. It's really important for us to catch any changes very quickly so that we can treat the patient at the beginning, at the onset of symptoms, to improve any outcomes that we're going to have with our patients. On the second page is the CRS grading, and we use basic vitals to grade any CRS that could be monitored. So we use fever, hypotension, and hypoxia to grade any CRS. This tool is vital in monitoring our patients and improving outcomes so that we can really notice anything right at the onset and treat the patient accurately and effectively. We keep these assessments that are done daily in a patient-specific binder at the nurse's station so that they're easily accessible and we're able to look at past assessments and notice any distinct changes that could be happening day by day.
Thanks, Tessa. Usually the nurses have done these assessments before the physician comes in a room, so it's nice that we have those available to look at. Next issue that we deal with, infections. These patients, after they get that chemotherapy that we talked about, their blood counts can go low. So if they have a fever, we can't all the time just say, well, this is CRS, I'm not going to give any antibiotics. So infections can happen and we treat for those as well. And then we do a lot of prevention of infections, very similar to how we do our stem cells transplants, where we prevent against bacterial infections, fungal infections. I still call it PCP because I guess I'm getting old, but it's PJP these days. And then protecting their intestines as well. And then targets, what's the best target? We know in lymphoma that we use CD19, but what else can we use? And is it going to have off-target effects? So that the new CAR T that I was telling you about for myeloma, the GPRD5C, I think I said it right, is also, that receptor is also in your hair follicle. So what we don't know yet, and we'll be interested to see, are people going to lose their hair? Are they going to lose their hair permanently? Is it something where their hair will grow back if the T cells stop working? So really you want to pick something that's unique to the cancer cell. And you can see here all the different research in this table that's going on in different targets that we're looking at for blood cancers as well as some different solid tumors. So moving forward, what do we have to do? Well, we've got to learn how to time these. Should we be doing these instead of transplants? Should we be doing this kind of therapy right off the bat when people get diagnosed? Do we save it for when patients' lymphoma or different cancer has come back a couple different times? Should we be using a CAR T cell that can see 2 different antigens and not just the one? Should we use one CAR T first and then use a second product within so many days? Should we pair these with transplants? How do we turn them off? What happens to the immune system, after you wipe out the T cells? So there's a lot of different things that we're thinking about and how to make these therapies better. But I think what's for sure is that you guys are going to see a lot more cellular therapy coming down the pipeline, just in the oncology care of patients in general. And that's it. Thanks so much for having us.